So Aiden, I will let you
Yeah,
take over.
yeah. And just a reminder to everyone, if you don't wish to be recorded, you are welcome to turn off your own cameras. So I'll just introduce myself. My name is Aiden Farrow. I'm an uninvited guest. I'm talking to you today from the unceded traditional territories of the Lekwungen speaking people, otherwise known as the Esquimalt and Songhees Nations. I'm a newcomer to Canada. I was born on Ngunnawal country in Australia, and lived the first 24 years of my life there, and moved to Italy where my two children were born and raised. And then after 24 years in Italy, I've now been 6 years here in Canada on the Lekwungen territories, and I'm very grateful to be here. I've been working for FNHA as a maternal child and wellness specialist for Vancouver Island for just over a year now. And previous to that, I worked for the Victoria Native Friendship Center in the early childhood departments. I'm talking to you today as a lactation consultant. I was just realizing my eldest child is turning 23 this year, so it's been 23 years since I first learned about breastfeeding. I managed to grow up with no experience of breastfeeding whatsoever. I had never seen somebody breastfeed. I knew nothing until my peers, my people my age, my friends and family began to have their own babies, and I was very happy to be in Italy because it was just expected. It was something that everybody did, and although many Italian women stopped early, it was very common when you went to visit somebody at their homes that they would just be breastfeeding in front of everybody, which was quite different to my Anglo-Saxon upbringing, my very white upbringing, where, I had never seen anyone breastfeed. So I became very passionate. I fell in love with breastfeeding immediately from the first time I saw I was sitting in a circle and watching this tiny newborn lying on a carpet, on a quilt in front of her mother. And, she was sleeping, and then she just kind of wriggled. And then this mother just picked her up and popped her on her breast. And I was fascinated that how she knew that, that's what the baby wanted, and the baby was quite happy to do that. And from that moment, I was, quite enchanted. And although I felt quite prepared, both of my breastfeeding experiences were quite difficult for different reasons. But I believe that's how I came to become a lactation consultant. I started as a volunteer with La Leche League, and then I became a lactation educator. And then it was quite a hard journey to becoming a lactation consultant because I wasn't a medical professional, and I had to go back. I had to go to university at the age of 42 to learn some difficult science topics, which at the time I was a little bit reluctant and a little bit resentful. It's like, why do I need all of this science and biology and pharmacology and so on and so forth? And today, this week, while I was writing this presentation for you all today, I was just so grateful to have studied those topics, because when we talk about medications and substances and milk, it's where knowing the biology and the pharmacology and the chemistry of how these substances pass into milk, and if they pass to the baby or not. So I was just very grateful today for having done those difficult university courses, so I could bring that information to you, or to understand the information that I'll share with you today. So I'll just look at my notes. So just a quick note about language. I identify as non-binary and transgender, which means I don't identify as a man or a woman, but somewhere in between. And so I'm quite conscious that, I personally use the word breastfeeding to describe my experience with my two children. But some transgender men, two-spirit people, and non-binary people don't feel comfortable with the word breastfeeding, because for some people it has a very strong female, feminine connotation, and some transgender men and two-spirit and non-binary people prefer the word chest feeding as a more masculine term. So I will, I will try and alternate between the two and use both, and talk about both mothers and women and parents and life givers and lactating parents in an attempt to include everybody. And I'm open to any language that I may not know of and that other people may wish to share with me. So this week's webinar series, well, that began last week and continues this week, is very much about supporting healthcare providers and community members to support the life givers and lactating parents in your own communities. And I'm just going to pull up my presentation. I'll just some technical difficulties, so I'll just share my screen. Just pull up. Barb, you can see my first slide.
Yes, thanks.
Yes. Should I hide my thumbnail videos? Can you see? Yeah, just put these down. So,
Is it
So
large
my-
enough for everybody, or do people want it a bit larger?
larger. Will that go out of the screen if I do that?
Let me just move away some of the stuff that's on my screen. Nope, it looks perfect.
Yeah, okay. So my talk today is milk medicine and substances. And I chose this topic because I thought it fits really well with this year's Indigenous Milk Medicine theme, which is mind, body, milk medicine. And the reason I thought about this was because pregnancy and early parenthood and the responsibility of caring for and feeding a baby affects us deeply, mentally, physically, as well as on many other levels, such as spiritually, culturally, financially. It affects our identities, our work, and our independence. And while there's a lot of joy in parenthood, and there's also a lot of selflessness and giving to the newborn, and that conflicts with a sense of self-preservation and needing to care for ourselves. And I know that breastfeeding and chest feeding can feel at times like a burden and a responsibility. And on the good days, it can be amazing. And on hard days, it's hard. And I feel like often it's not talked about enough by healthcare providers. I think when I learned to breastfeed, there was very much, it was the best and it was wonderful and, you would enjoy it. And it was the perfect food and all of these things. But then the reality was, was different. And I know it's different for everybody. So in Canada, we have quite high breastfeeding initiation rates. I'm not sure how to get my slides to progress. Oops. So is there anything covering the words on my screen? So Canada's, so in Canada, we have quite high breastfeeding initiation rates. So this is Canada's breastfeeding progress report from the Public Health Agency of Canada in 2022. And 9 out of 10 mothers or parents initiate breastfeeding. And in BC, that's even higher. It's 96.4%. But then 1 in 7 mothers stop by 1 month, and 1 in 5 mothers, and this is the language they use, and 1 in 5 mothers stop by 6 months. And so as someone who's passionate about breastfeeding, I'm always curious to know why. And is there something we can do to support parents to, is this what they wanted and did they wish to breastfeed for longer than that? So statistics only tell us so much. Some stop. So of those who didn't initiate breastfeeding, almost half of those, 41.8% of those who didn't initiate breastfeeding, so this is quite a small number, it's less than 1%, stated that the reason was a medical condition or illness of mothers. So even though it's statistically quite a small number, we know that that can be quite a number of people who didn't start breastfeeding because of a medical condition or illness. And, medical condition or illness often comes down to medications. If you think of cancer, for instance, it's not the illness in itself that typically prevents someone from breastfeeding. It's the medications, or if we have if we have like chickenpox, for instance, which can be quite devastating for a newborn, mother might not be too sick to breastfeed the baby, but it can be too contagious, for instance. When I first looked at those statistics, I thought, oh yeah, too sick to breastfeed, and then I thought, no, it's often something else. It's often the medications. So that got my mind turning on to this topic. And of those who did initiate and stopped by 1 or 6 months, around 8 to 9% stated that it was a medical condition or illness of the mother. So, and I know this from my experience that often, someone will stop breastfeeding because they want to go back. They might have stopped their anti-anxiety medications or their ADHD medications or their antidepressants or some other medications, and they stop because they want to go back on those medications. But I also know from experience that, most medications are compatible with breastfeeding. And sometimes doctors will say that something is not compatible simply because they don't have the correct resources. I thought this was a really good topic for today, was how to, this conflict between wanting to care for oneself and whether that's through medications or substances, which, there's not a strong, it's not like medications stop and then substances start. There's kind of a continuum there. So I know that, there's a lot of misinformation about medications and human milk, and how it's a barrier to breastfeeding and chest feeding. And what do we know about the mothers and parents using substances? Are we seeing that in our statistics? So when we're looking at reasons why parents are stopping breastfeeding, are they in those statistics? They're not technically an illness, or maybe they're in the other statistics, or maybe we're not counting these mothers and parents at all. So I found a really interesting research study about medications and lactation, which answered some of the questions. And this was a research study from Alberta that surveyed mothers with chronic health conditions. And there were 3 groups of mothers in their research. So all of the mothers had chronic health conditions. Some were using no medication for their condition prior or during breastfeeding. Some were using medication prior to breastfeeding and stopped while they were breastfeeding. So they stopped taking those medications because they didn't think it was compatible with breastfeeding, or they didn't feel comfortable. And some were using medication prior to breastfeeding and continued while breastfeeding. And the results are quite interesting. So there were women with chronic conditions who I broke this sentence up because it was quite complex and tried to simplify it. So women with the chronic conditions who discontinued their pre-existing medications while breastfeeding, they stopped breastfeeding earlier and were less likely to meet their breastfeeding goals in the first 6 months compared to the women who continued their medications. Those who continued their medication throughout their breastfeeding or weren't taking medications at all had similar rates. So just to clarify that, we had 3 groups of women. They all had chronic conditions. Some of them were taking medications either during pregnancy or probably during pregnancy and before they started breastfeeding. And some of those women who were taking medication stopped because of breastfeeding. Some continued. And some had never taken medications, but they had chronic conditions. So the group that discontinued their medications stopped breastfeeding earlier than the others. So I was just wondering if anyone could put, whether you want to take the microphone or put in the comments, can you think of any reasons why the women who stopped taking their medication stopped breastfeeding earlier? Try and take a guess at that, or and this was a survey, so we don't have those social science questions to answer this question, in fact. So I'm just going to guess that those who stopped breastfeeding earlier were because they wanted to start their medication again. And so when we look at reasons for discontinuing, we know that not being able to take a medication during breastfeeding is a reason for that women do stop breastfeeding. And so I wanted to look at ways that to promote the fact that so many medications are compatible with breastfeeding, and breastfeeding needs to be sustainable if it's to continue for the long term. And we can only give up so much for so long. So when I was a new parent, I gave up everything. I gave up coffee. I gave up alcohol. I gave up sugar. I gave up so many things out of anxiety and wanting to do the right thing and to give my child the best start possible. But that's only sustainable for so long. And the same with medications. Some others give up. As I said, there are ADHD medications, there are antidepressants, there are anti-anxiety medications, and a lot of mothers and parents use substances as a form of self-medication. And so, when we take away something that we need, we can only maintain that for so long. So I wanted to look into how we can support mothers and parents to look after themselves, to keep themselves safe and to keep their babies safe. So I thought I'd look at why do we breastfeed and chest feed, because there is this conflict between our own needs and the needs of our baby. And, especially for any of you who have breastfed beyond the first couple of months, you can have some really difficult times. And so, I wonder if anyone wants to put into the chat, for those of you who have breastfed or who have supported people to breastfeed or have seen family members and community members going through difficult breastfeeding experiences. What are the kinds of things that drives us? What are some things that make us want to breastfeed even when it's difficult?
If people want to write things in the chat, I'm happy to read them out. So there's cost, bonding and attachment, convenience. I think another example I've had, Aiden, is sort of a bit of a flip one, is someone that I was speaking with who was talking about a friend when she was saying this, so I don't have many details, but the person was still breastfeeding at 2 years because she didn't want to start using again. And so as long as she was breastfeeding, she felt she realized or recognized or didn't want to use substances. So she was continuing to breastfeed. So now afterwards, when I thought about it, I thought, is it, was that person doing it for themselves, or was it also their way of saying to their perhaps their partner or their friends they hang out with, they could use breastfeeding as an excuse as to why they weren't using, whereas once they stopped breastfeeding, if they didn't want to go back to using, what were they going to use as a reason for not doing that? Whereas the breastfeeding kind of gave a good reason for not doing it, and people were willing to accept that. Or was it
Yeah.
their own personal belief that they didn't want to? It's like, which
Yeah.
side of the coin did it come from? But I thought it was really an interesting one to hear.
Or all of the above,
Yeah, or all the above. Yeah, exactly.
I think, is feeding a baby or having a baby and, being a parent is such a stimulus to be the best versions of ourselves. That's within our capacities. We want to be good parents for them. So it's complex. Yes, it's very complex. So I just put some thoughts here of so bonding. I noticed that in the chat because we have to, and I think there's different. I put that there that could have so many meanings to it. I was thinking back to Inez's beautiful presentation from Friday where there was there was a strong expectation in her family that the women in the family would breastfeed. For me personally, it was, that belief that breast is best. And there was a lot of health promotion at the time that made me feel I had no other option. Because we have to, sometimes it's for financial reasons. We don't have a choice. We can't afford formula. Sometimes we have to breastfeed because our breasts are full of milk and we need to relieve that. There's lots of reasons. And we breastfeed because the baby wants to feed and has so much joy in it. And, there's so many reasons. And human milk is unique. I always try to bring this into my presentations because human milk is for humans. It's unique to humans. It has benefits to both the parent and the baby. It's the biological norm. It's medicine, as Indigenous Milk Medicine Week brings the highlight on. So there's so many reasons. But Barb, were there any more in the chat that I haven't covered?
Social pressure.
Social pressure, yes, and sometimes
long-term health effects. It's a special gift. Convenience.
Yeah,
I think you've tapped into some of those already.
Yeah.
And
I did think
of it personally important. Yeah,
personally important. I did think of it as a gift. I was thinking the fact that it can sustain life for 6 months without any other. We can sustain life for 6 months without any other food or drink. Our babies don't need anything else for the first 6 months. And I thought, wow, that's like, one of those food delivery subscriptions. We get 6 months of milk delivered to our homes for our babies, through our bodies. And, I spent some time like going back through my textbooks and seeking online, etc. Like, how exactly do we make this milk? And it's quite incredible that we can make milk in these tiny little sacs in our mammary tissue. We can produce up to a liter of milk a day for our babies. And if you're breastfeeding twins or chest feeding twins or triplets, that could be 2 or 3 liters a day. And I think the fact that we don't see that milk unless you are pumping, I did have to pump for some months for my baby. So I was quite aware of, how many bottles of milk I was producing a day. But it's quite phenomenal if you think about quantity of milk that we are gifted. And not to say that it's easy or free in relation to time, or if you need support, or if you need a breast pump, or any of those things. But it's definitely a gift that yes, as I said, it's a life-giving substance. It can sustain life for 6 months, and it continues to be an important source of nutrition during the first 2 years and beyond. So human milk is unique, and one way of really making that clear is I'm always interested in looking at other mammals, especially like the really strong, majestic mammals. And so I did a little bit of research onto whale milk, and was just really fascinated to see that whale milk has you know, obviously it has a very high fat content compared to human milk because whales have to put on a layer of fat very quickly and they live in very cold waters. And the milk is very thick because, you know, it can't get lost in the water. And so whale milk is described as like having a toothpaste consistency or like yogurt. And, you know, when I read these facts, I think, wow, that's really amazing. And then I look back at our own milk and it's amazing in its own way. And so each milk is unique to its own species, and human milk is unique to ours. And something specific about our human infants is brain development. And so our milk is designed not only to grow bodies, to grow the immune system, but also to grow these quite remarkable brains that we have. And breastfeeding and chest feeding has benefits to the parent, and you know, times these were the things that I thought about and that kept me going when things were difficult or when people were criticizing me. And I think lots of us get criticized for breastfeeding, even though we're doing something quite special. So it reduces the risk of breast cancer and ovarian cancer. It reduces the risk of type 2 diabetes, and it reduces the risk of high blood pressure. And breastfeeding and chest feeding reduce the risk in infants of asthma, obesity, type 1 diabetes, sudden infant death syndrome, ear infections, and gastrointestinal illnesses. And the second last one, my second child was born with a cleft lip and palate, and children with a cleft lip and palate are quite prone to ear infections. And so that in particular, you know, was one that I really held on to, and, you know, just reminded me that there were good reasons for doing this work. But despite our milk being so unique, I think all of us worry at times that our milk isn't good enough. You know, it's not good enough if we take that medication. It's not good enough if we drink that cup of coffee, or if we have a cigarette or an alcoholic drink, or if we use cannabis or other substances. And so, like, the current thinking in lactation and pharmacology is to weigh up the risks and benefits of. A is to show if there are any risks and what those risks are. And as I said, most medications don't pose any risk to infants. You know, the dose is quite small in most cases. And when there is a risk, it's to weigh the risks and benefits. For instance, you know, babies that are exposed to substances such as commercial tobacco or alcohol or cannabis or other substances, sometimes they're the babies that most need the benefits of human milk. So, you know, so we need to take a harm reduction approach and also you know, an informed approach to supporting parents to make sure that they have the information, and we have the information to support them in their decision making, and to make sure that they're safe and their babies are safe. So how do we know how to support these families and community members with these decisions? So, so specifically to medications and milk, as far as I know, doctors in Canada use something called the Compendium of Pharmaceuticals and Specialities, the Canadian Drug Reference for Health Professionals. And this contains monographs, you know, the pages that come with medications that are provided by the drug companies. And, you know, this is excellent information about dosages and side effects, but they do tend to be conservative when it comes to breastfeeding, and they say that it's not recommended or not, there's not enough information to recommend. And it's understandable why the drug companies would be more conservative, because, you know, they're not working directly with the parent, and these are individual evaluations to be made between a parent and for their particular illness, medication requirement, or substance use. So there's lots of more in-depth information. Unfortunately, there are databases that doctors, health providers, parents, and families themselves can consult. So for instance, we have LACMed, which is a US government online database, which is free to access. There's the Infant Risk Center in Texas, which is a phone line and a forum, and it refers to the information from Dr. Hale. Dr. Thomas Hale is the author of a book called Medications and Mother's Milk, which is a huge book with well over 1,000 medications. It has more medications than LactMed and Alactancia, the next database that I'll talk about. And he has two apps, one for parents and one for professionals. These are the book, and the apps are purchasable. And his book comes out every 2 years, whereas his apps are updated constantly. And the LactMed is updated consistently. And Infant Risk Center is a phone line staffed by retired nurses who refer to Dr. Hale, and they also run a forum. And then Alactancia is a bilingual online database maintained by Spanish pediatricians in English and Spanish. And I've mentioned all of them because, particularly if you're looking into medications or substances for yourself, for a community member, for somebody you're working with, then it can be useful to look at more than one database if it's a complex situation. And I'm just going to show you some of these websites. So this is Alactancia, which is the Spanish English one, and I'll show you an example if they have ibuprofen here on the web page. So it immediately they're color coded, and it's immediately clear that it's a safe substance and breastfeeding is the best option. There's no need to stop. And there's a bit more detail here for providers. Infant Risk Center is out of the Texas Tech University for the Health Science Center. Even though it's in the US, it's on it's got the hours of opening and the phone line, and there's also a forum where you can access information. And this is a really great resource for when you really can't find information and need some help navigating. They also have a wonderful breastfeeding section where you can find information for things like sunscreen, which I hadn't even thought about, the absorption of sunscreen into the body and into milk. Talks about things like migraines, dental fillings, vegan diets. So there's a lot of really up-to-date information here. So I don't have a copy of Hale's book, but Dr. Hale created a lactation risk category. He goes from L1 through to L5. I don't know if you can see them here, but L1 is something like Tylenol, Advil. He has antibiotics here. Some of them are L2, which is safer. So L1 is safest, L2 is safer, L3 is probably safe, but no controlled studies, or risk to infant is possible. L4 is possibly hazardous, and L5 is hazardous. And so that's where, temporary or complete weaning from the breast would be necessary. So they have this handy little sheet here with some really common medications like pain relievers, antibiotics, cough, cold, allergy medications, birth control. This is the drugs and lactation database, LactMed. It has, as you can see, an alphabetical list here, and it has everything from antibiotics and alcohol and alfalfa and aloe. So it has herbs, and it has safe medications through to things like chemotherapy and radiation. Other sources for more unusual situations are the Journal of Human Lactation, which unfortunately is behind a paywall. The Academy of Breastfeeding Medicine, which is also a journal behind a paywall, but they do have free access to their breastfeeding protocols, which do cover things like cannabis and medications. International Breastfeeding Journal is free access. So this is another place to look for information, case studies, etc. And then we have the BC Association of Pregnancy Outreach Programs that has an amazing page on perinatal substance use with their handbook, their tool cards, their harm reduction resources, best practice resources, substance-specific resources for professionals on things like alcohol, FASD, cannabis, nicotine, opioids, and naloxone, down to support for participants who use substances. So I'll just pull up my presentation again.
Aiden, I've put the links to the different,
Yeah, I have those in my,
yeah, I put them in the chat for most of them.
Yeah.
Not the journals,
Yeah,
but the
yeah.
websites.
Yeah, I also have them in my final slide. So, and something that I found very interesting to read in some of these databases was, some emerging research on chemotherapy. And for example, chemotherapy was always that example I used as something that, was incompatible with breastfeeding. And so it's very interesting to read the latest research about chemotherapy and how therapies are evolving from intensive treatments to maintenance therapies. So it might be a very high dose, it might be a very low dose, and it's not necessarily the end of breastfeeding, especially for those parents who are very determined. And there's a big body of emerging research thanks to women who've expressed their milk during chemotherapy treatments, as in daily or twice daily, to see the levels of chemotherapy drugs. And so there are quite complex medical issues where with drugs like chemotherapy, where parents are questioning and being involved in research and finding ways to breastfeed between cycles, or to maintain their breastfeeding through pumping until the end of their treatment, and then until the medication is cleared from their body. And so it's a very fascinating area of lactation. And so, yes, here I put links to this. So I know that was a very brief tour of the topic. So I wanted to open the floor to any questions and thoughts, and any questions that I might be able to answer on, the topic of medications and substances and human milk.
So Aiden, there's one question in the chat saying one class of medications chest feeding parents are concerned about taking is anti-anxiety and antidepressant medications, which may delay them seeking treatment or cause them to consider stopping breastfeeding.
Yeah, absolutely. Yeah, this was a class of medications that when I, 20 plus years ago, we thought they were really contraindicated. So I'm just going to take you back to I lost my way out here. So I'll take you back to I was going to pull up some examples of this. So here, if we go to, this is the Thomas Hale flyer. So we have, so if you think L1 are the safest, and let's have a look here. Can't see them both on the same screen at the same time. So antidepressants, we have at the bottom of the page, we have SSRIs like Zoloft, sertraline, Paxil, Lexapro, escitalopram, etc. And these are L2, and bupropion, Wellbutrin is L3. So if we go back to the lactation risk categories, L2 is safer, limited studies done without an increase in adverse effects in infant, and L3 is probably safe, no controlled studies, and risk to infant is possible. So the Lactamed database, the Electansia, and Thomas Hale's book, apps, and his the forum, and the ToxNet phone line, etc., have more information about what that would look like if a parent were taking these medications, and what to look for if there were any risks. There's these resources would show what a relative infant dose would be, and any relative infant dose less than 10% is considered safe. But then these would be decisions to make together with, with the prescribing provider, and who would then give, if there was any concern whatsoever, that the parent would be provided with the information on what to look out for if it was irritability or digestive issues, loose stools or something like that. So thankfully, a lot of antidepressants, anti-anxiety medications are actually safe, which is great news.
And I know I had a
Yeah.
mother once that needed to go on the medications, and they also offered her that if there was any, now this was quite a few years ago, but if any worries, they could do blood levels on the baby just to ensure that the baby wasn't getting too much into their system. Although the Hales book talks about that. If you go into the Hales book, they'll discuss if there's been studies done looking at how much is actually getting through to the baby, either during pregnancy, through the placenta, or postpartum through breast milk. So there's lots of information out there to support the use of the meds.
And it also depends on the age of the baby, their size, the kind of medication, how it's bound, et cetera, et cetera. But as you can see, all of these are on the L1 to L3, so they're considered quite safe. But the L3 is where it's probably safe, no controlled studies, risk to infant is possible, but the resource would go into what those possible risks were. And we're not talking about hazarded risks here. It would be rated much higher, to L4, L5.
So Geiger just put up in the chat another new platform that's being developed in Ontario called the Welcome to First Exposure. Which it says your trusted source of medication and substance safety information for pregnancy and lactation health. And they have all these great drop downs from the looks of it. I've just pulled it up. So that's another one that people can refer to.
From the University of Toronto. Okay. Here we go.
Aiden, do you want to talk a little bit about pump and dump and how to do that differently and when it can?
So
times and why and stuff.
So I might just put this down and stop sharing and stop sharing. So pumping and dumping. So long time ago, when I first 20 plus years ago, it was thought that things like alcohol, that if you pumped and expressed your milk, then the substances would leave your milk faster. And that's found to be, in many cases, not true. So for instance, with alcohol, your blood alcohol level is very similar to your milk alcohol level. The alcohol actually passes back and forth between your blood and your milk to maintain equal levels. And so as your body is the alcohol is leaving your blood, it's also leaving your milk. And so, rule of thumb is something like, for each standard drink, then it's 2 to 3 hours before it leaves your bloodstream. And so pumping milk in that period isn't going to make that happen any faster. It's just something that's, cleared through your body, through your, your liver and your kidneys. But pumping and dumping can, for example, let's say you were going out for a night, leaving your baby in the care of somebody else. You wanted to have some drinks and you weren't planning to breastfeed again until all of the alcohol had left your system the next morning. But depending on how young your baby is and how frequently you're breastfeeding, you may not be able to go that long without breastfeeding. And so that's where you would be pumping, not to remove the milk from your body, but so you don't get engorged. And because there is alcohol in that milk, it wouldn't be indicated for your baby, but it could be used, for something else, like a milk bath, or I guess, I don't know, Barb, is that safe, a milk bath with alcohol in it? I don't know. So you use it for milk jewelry, for their own skincare. Yes, okay, I'm not going to put your baby into a milk bath with alcohol. But yeah, so it's pumping and dumping in this case would be to maintain milk, to prevent engorgement, and to not skip a feed body, but it's not removing the alcohol from your milk. A different type of pumping and dumping is where, for instance, if you're having a radioactive contrast fluid in your body for, I believe that's for MRIs or CT scans.
CT scans, I think.
CT scans. In that case, pumping and dumping is actually helpful for moving those radioactive substances out of your body. So there's two kinds of pumping and dumping. One is simply, there's a substance in that milk. For instance, a mother or parent who's going through chemotherapy who might say, well, for 3 months, I'm going to pump and dump my milk because I can't feed that milk to my baby. But when my therapy is finished, I want to start feeding. So that would be pumping and dumping because it's not usable. And it's to maintain milk production. But it's not the same pumping and dumping as with the radioactive substances, for instance, where you're moving that out of your body faster. So there's two types of pumping and dumping.
And then the other part of that conversation can be in preparation for, again, if somebody is wanting to go out to a party on the weekend, or wants to have some alcohol on a specific night. If they plan ahead and pump ahead of time, so they basically store the milk, the milk, and then during the time that they're drinking, or they might not even be home, and whoever's looking after the baby, but even when they do get back home, they'll still have the alcohol in their system for a period of time. So they can be using that milk that they pumped ahead of time before they were drinking. And so the baby can still have breast milk during the time that they're using alcohol. So it's another way of maintaining a baby to continue having breast milk, even though the parents or the parent at times may not necessarily, the milk is not going to be, that's online, isn't going to be able to be given to them.
Yeah. And these are times too when hand expression, learning to squeeze milk out with your hands. If you're not saving that milk, then it's one really great way of learning to hand express is under the shower, for instance, or if you're going out and you were just in the bathroom, you could express into the bathroom basin and rinse it away. So we don't necessarily have to have a pump to remove that milk if you're relieving engorgement or pumping and dumping. So
now the difference with cannabis is it stays in the fat cells for longer. So there's more of a challenge. With the alcohol, the person can go out and, let's say, drink in the evening time, and then depending on how much they've had, so many hours, it will be cleared from their body, and then they can start breastfeeding again. There's a bit more of it's a bit more complex with cannabis because of it.
So cannabis,
body longer.
So cannabis is really a new area of research because it's so recently become legalized, and so usage has become much more open and varied and much more common to be talked about. And it's also one of those substances that is also being used medicinally. So we're looking forward to a lot more research because the current recommendations are there's no known safe amount. But then if you go into these resources that I've shared with you, you'll learn that there are different types of cannabis products, and then for instance, cannabis, that's the plant that's grown today, has much higher levels of THC than it did 30 years ago. So this is where the pharmacology is really important, is understanding like how much THC is in a cannabis product, and how much is absorbed by the parent, and then it does stay in your fat cells. So what does that mean? And how much is the relative dose is the infant getting? So it's, there aren't any kind of cookie cutter answers when it comes to a substance like cannabis, because it's a plant, and because, the leaf and the bud and the resin, and there's a lot of different products. And then some of those products have are just the CBD or the THC. And so it's really something to look into for an individual and products they're using. And but yes, it does stay in the so once it's left the milk, it does, however, stay in the body fat, and it does show up in the infant's urine for even for weeks after usage. So, but what that actually means is a bigger question. So yeah, no, it's definitely something that's emerging research. It's complex, and there's some approaches that there's no safe known amount, and a harm reduction approach is to, well, let's look at your usage and let's evaluate what the risks are and what we know.
So that's a good segue into talking about promoting tomorrow's webinar, which is around empowering conversations, where Renee McEwen and Tony Winterhoff will be doing a presentation on how to have these discussions, various discussions with families and with parents and with mothers, especially around these more kind of challenging type conversations, potentially challenging or difficult ones. So that is the presentation for tomorrow, which kind of leads from some of the discussion today around the different topics, the different discussions that people are having or may need to have, depending on what type of substance is being used. The other thing was just to mention too is Aiden mentioned the BC Association of Pregnancy Outreach Programs, or BC POP, and their substance use guide. They have a lot of information on there around substance. Obviously, it's around substance use, but they do have some really interesting little cue card things as far as that you can ask parents, or parents can.
Those are linked. They have wonderful resources.
Mm-hmm. So yeah, it's a great website.
They have wonderful little postcards.
Yeah. So if you're not familiar with that site, we would certainly recommend going onto that site. And I'm not sure if that's one of the ones I put up on the website or not, but if you just go BCA POP, it will Google it. It will come up, and then you just look at perineal substance. I think I put it up already. Just a few more of the in the chat, just to finish off before we finish today. Just kind of where are these websites? There's one that Lee put up around a webinar that's coming up on new medications and mother's milk, with the registration link that she provided in the chat. And there's also this, we already mentioned that, the first exposure website. And Emma Garrett mentioned, hoping that this kind of information is being circulated more widely. It is so important to support parents' mental health, including ongoing use of medication. So, this is just one webinar. Certainly we could have one, with a lot more detail specific to just, let's say, substance use. This was kind of more of a general one for the purposes of these webinars. And Jen put up another homepage for Mother to Be, which is another resource. So hopefully you're looking through the chat, because there's lots of different information on here. Another one that Lee put up around Trash the Pump and Dump, which is another link. The next version of Baby's Best Chance is going to provide some great guidance for parents on drinking and infant feeding guidance, which will be fantastic. And that is supposed to be coming out in the fall, if I'm correct. Lee can update me on that one. Maybe they've changed now. And Lee also put up a link to around medical imaging testing and breastfeeding. And what else is there? Perinatal Services is developing a 2-pager patient parent resource on drinking and breastfeeding, which will be wonderful. Lucy put up around the Indigenous doulas are meeting in October in Harrison. Great to have a presentation submitted with these amazing resources. That's a great idea, Lucy. We'll think about that one.
Okay. So what we can definitely do is collect all of these resources from the chat and thoughts, and collect them together with the resources that I've linked to, and then distribute that
yes.
to our to our mailing list.
And what we thought we would do is for National Breastfeeding Week in October, sort of do a follow-up to these webinars with a resource list and be able to talk about the resource list and the information that's in it, and other topics that have come up as a result of the chats during this one. So just to finish off, because we're at time, I appreciate everybody attending today. Hopefully you'll be able to attend tomorrow. And I think just as a closing note, one of the chats items that Lucy Barney put into the chat, which I think is kind of a great closing statement around breastfeeding, is that it's an age-old practice that was normal, and that still is normal.
Yeah.
And breast milk is baby's first foods. So that's not exactly the way you've said it before, Lucy, because you have said that statement in the past, but something similar to that. So if you have any other questions, just put them in the chat before you leave, or message at mchnursing@fnhj.ca. And otherwise, we'll see you tomorrow. And thanks for showing up, everybody.
Thank you, everyone.
I want to stay on just because I want to make sure I've highlighted, I've copied and pasted most of what's in the chat, but before we leave.
Yeah. So is that archived, or do we need to?
I think I can archive it with Zoom. I haven't done it on the other ones because there wasn't, we've still got people on here. Let me just,
Your recording's on too. Do you want to stop?
Oh, yes.